Good afternoon, everyone. Welcome to the program today. Give me great pleasure, to introduce Professor Lim Soo Tek and myself here. I'm Dr. Liu Hongbang. Dr. Lim Soo Tek is from Singapore. He's the head of the cardiology department, a senior consultant at the National Heart Center, Singapore. He's also the director of interventional cardiology and director of medical informatics there. In addition to his training in Singapore, Professor has specialty training in US. He has worked in Michigan. He has worked in Boston. And he's currently also the chair of the chapter in cardiology of the Academy of Medicine in Singapore and an expert panel for International Atomic Energy Agency, radiation protection. So I think without further ado, I'd like to invite Prof. Lim to say a few words and give his, I think the first highlight of the day is sharing his knowledge and experience in dealing with ostial lesion. Prof, please.
Thank you very much, Hong Kong, for your kind introduction. And it is really a great privilege to participate in this Alvimedica Academy program. I hope to share some of the very little that I know about this ostial lesion and the ostial lesion PCI, and some of the practical things together with some of the basic knowledge required for the ostial lesion PCI. This talk will be actually quite a basic one. All right, for those who are the high volume operator, perhaps it is not as relevant. And this one is just to provide a background to the cases that Dr. Liu will share afterwards to talk more on the 5 points of the ostial PCI intervention. Okay. So the definition of the ostial lesion traditionally is defined as those located within 3 millimeters from the vessel origin. And the classification can be, for location-based classification, can be divided into aorto ostial lesion, non-aorto ostial lesion like that of LAD circumflex, or the branch ostial, colored blue in this diagram, that of the smaller branches. The causes can be that of atherosclerotic lesion, can be due to aortitis, can be due to mediastinal radiotherapy. And typically, they are more fibrotic and often calcified and more rigid and has higher recoil and therefore higher restenosis rate and associated with a lower PCI success rate and a higher complication. When we see a ostial lesion, the first thing is to evaluate the physiologic significance of the ostial lesion. It is actually notoriously difficult to assess accurately using angiography alone because of the vessel overlap, because of the angulation, because of the artifacts. In fact, we often hear from the cardiothoracic surgeon that we send patients with the ostial left main disease to the for surgery, and they do not find significant ostial left main lesion at the time of the bypass. And then so for the physiologic assessment of the ostial lesion, I think that the resting or the hyperemic physiologic indices will be of great help. When we perform, I understand that there is already a physiologic session during this Alvimedica Academy series, but just a few points, but specific to the ostial lesion. For aorto ostial lesion, the initial pressure equalization can be done in ascending aorta prior to vessel engagement. And then disengage catheter during the FFR, or the resting index measurement. And to perform the hyperemic FFR, IV adenosine and not the IC adenosine is preferred. For the non-aortic ostial lesion, it can be performed as per normal. We should also remember that the angiographic and the IVUS parameter has a better correlation with the FFR in main epicardial vessel, the left main LAD, circ, and the RCA. But it has a very poor prognostic, the diagnostic accuracy for predicting functional significance of side branch ostial lesion. I think this is perhaps a very important point for all of us to remember, that for the side branch ostial lesion, the angiographic and the IVUS parameters correlate poorly with the physiologic parameter. This is one of those studies from Korea that look at this correlation of the angiographic and the IVUS parameter with the FFR. And you can see that in the main vessel here referred to those in the left main LAD, circ, and the RCA, there's a slightly better correlation, whereas for the side branch ostial lesion, the correlation is poor, either poor or no correlation at all. Even for the main branch, main vessel ostial lesion, you can see that there is quite a wide scatter. Therefore, if there is any doubt about the physiologic significance of the ostial lesion, we should perform the appropriate physiologic assessment. Just an example of this, you can look at this angiogram that show the ostial LAD and also an ostial diagonal lesion here. The ostial diagonal lesion look especially tight on the angiogram, and there's mild to moderate disease in the ostial LAD. And I run the IVUS in. Yeah, this is pulling back from the diagonal one, and you can see that there's actually negative vessel remodeling at the ostium of the diagonal one. Yeah, here, and then there's actually minimal amount of plaque at the ostium of the diagonal one, and then going to the LAD. So this is not an uncommon finding. And yeah, when we evaluate the side branch ostium using IVUS. So in this particular patient, the MLA for the ostial diagonal one was 3.16 millimeters square, and then LAD 8.93 millimeters square with a plaque burden of 40% for both. And the physiologic indices, actually RFR and the FFR, were both not significant. So the lesion was left alone. Therefore, before intervening on a side branch ostial lesion, we need to consider the size and the amount of the myocardial supply and make sure that they're actually physiologically significant. And we should also consider whether there is any potential of main vessel compromise. I think that is an important consideration for isolated branch ostial lesion. This study, looking at comparing the interventional versus conservative treatment of isolated ostial lesion of coronary diagonal branch artery. This is mainly for the 001 lesion. We can see that the group with the no angioplasty at 12-month follow-up has actually a lower rehospitalization, recatheterization, PCI or repeat PCI in the conservatively treated group of patients. Once we decide on the PCI, then the catheter selection, guide catheter selection is important, and generally for aortic ostial lesion, less aggressive guide catheter, for example, Jacking catheter will be one of the preferred choices. This is to avoid deep engagement, and we can disengage more easily during stent placement. Of course, the guide catheter selection also depends on other factors. If there is an extensive calcified lesion that need more support, then appropriate guide catheter can be selected. And side hole guide catheter is not recommended. And then for a very tight aorto-ostial lesion, consider preloading the guide wire in guide catheter, and then for rapid wiring and catheter disengagement. These are some of the common curves used for the aortocoronary bypass graft lesion, GR4, multipurpose, left coronary bypass, and arm plugs to provide adequate reach and adequate support. The lesion preparation is important, not just at the ostium, but everywhere in the coronary tree where we consider stenting. But this is especially so when we talk about ostial lesion. And these are some of the equipment that we can consider to prepare the lesion depending on the lesion characteristic. In this case, just to illustrate the importance of lesion preparation, this is a patient admitted for inferior posterior MI, with the occlusion of the circumflex artery immediately after the major OM1 branch. After the thrombus aspiration, you can appreciate this the lesion here, and the operator, without further balloon dilatation, plan to implant a stent. The stent position appears quite optimal, actually, angiographically. Take note that this one is without the balloon dilatation after the thrombus aspiration. And take a look at this sequence when the stent is deployed. So here the balloon went up slowly. And just towards the end, before it fully engaged, there is a proximal migration of the stent. And the subsequent angio show that it actually crossed through the ostium of that big OM branch. So one important practical lesson to learn is that the ostial lesion need to be adequately prepared, and to minimize the likelihood of this type of imprecise stent placement, whether the stent balloon assembly move proximally or distally. This is an example of a patient with a severe eccentric calcific stenosis at the ostium of the circumflex artery. Initial attempt at just balloon dilatation because the IVUS couldn't cross, and this was the initial attempt at the balloon dilatation. You can appreciate that the balloon was not fully expanded, and this trunk of eccentric calcified plaque prevent the full expansion of the balloon. So on IVUS, this is pulling back from the proximal circ, and this part, this is the part with the circumflex artery lesion, ostial lesion, and you can see that it is eccentric, but actually the whole vessel has calcified plaque. But it is especially dense from 1 to 7 o'clock position, and this is back to the left main. And take note of the guide wire bias in this case situation. And because of this, we're making use of the guide wire bias, and orbital atherectomy was performed to this lesion. This is orbital atherectomy. And after that, a stent implantation with a side branch balloon in the LAD. And this is the final picture where the stent is actually quite well expanded, and the position was good based on the angiographic, and the IVUS assessment. For ostial lesion, angiographic views are important to keep in mind. The left main, generally epicrania or LAO crania. Sorry, typo error. RCA is LAO or LAO chorda, same as the RCA bypass graft. And then the LAD, usually a combination of chorda views. RAO chorda, least overlap with ramus and circ, but more foreshortened than the LAO chorda. Circumflex artery, usually LAO chorda, but sometimes LAO crania for more distal branches, especially for the dominant circumflex artery. Left coronary artery bypass graft, RAO, views with slight cranial chorda angulation, we need to separately determine. So, for example, this is one of those common scenarios where we need to stand the left main. Here, the LAO crania view show the ostium left main well. And then for the RCA, this is a positioning of the IVUS catheter at the ostium of the RCA, form a LAO angulation. And often, I also find this rotational angiography. If this is available in your lab, I think it's useful to provide multiple angiographic projection. In this particular run, you can appreciate that the LAO 30, crania 25, you can see the ostium of the left main quite well here. And this is another example to look at the circumflex artery and the OM vessel. And in this particular example, if we scroll back here, then we can see that we can determine the optimal angle to place the stent here, right? Approximately here. Yeah. Next, after the dilatation, we need to precisely place the stent. The ideal, of course, the ideal angle is a right angle, but rarely we get things like that, the angle like that. Then the acute angle poses various type of problems. For example, in the panel B, if we stand based on the lower lips, and if there is a lesion in the upper lips, then there is a geographical miss. If we stick it out a little bit, then there is a possibility of a plug shift, and there's also a slight proximal stent protrusion. In a big vessel, this is probably acceptable, but for the next intervention, the operator needs to be careful of not putting the guide wire below the stent strap. And then sometimes there is excessive proximal protrusion into the parent vessel, then making the subsequent catheter engagement difficult. So there are several techniques that can help with the stent placement. Dr. Liu Hongpang will talk more on the Sabo technique, which is one of the most important techniques for all of us to learn and to master. There are some other techniques, for example, the aorta free-floating wire techniques, like in panel B, and the stand drawback technique as shown in the panel C. And IVUS positioning guidance might be helpful, yeah, when we perform the IVUS evaluation, yeah, at the ostium. We take some fluoroscopic image, save the fluoroscopic image or the angio image, and then put the reference table position so that we can actually go back to the same position. That will help. The special devices and dedicated ostial stand, by and large, fallen out of favor and actually not available in most places. So we won't talk about it. So this is a aorta free-floating wire technique. These ostial and very proximal RCA lesion. After pre-dilatation, the operator put a guide wire here and then putting a stand in. In this particular video shot, the tip of the guide catheter appeared to be of some distance from the ostium of the RCA, but the presence of the guide wire prevent the deep engagement of the guide catheter, allowing the angiogram, this angiographic shot to be done for a more accurate determination of the stand positioning. So this is after stand implantation. Yeah, if contrast is not an issue, we can always leave the guide wire in the aorta and then take a proper shot. That will also minimize the likelihood of a guide catheter disrupting and causing damage to the proximal portion of the stand. The other technique that is useful is a stand drawback technique. Where the stand is advanced beyond the lesion, a balloon is advanced over the second wire opposite the ostium of the target vessel, and the balloon is inflated at low pressure, 6 to 8 atmospheric pressure, and then the undeployed stand catheter is pulled back against the inflated balloon until a dent is seen. Then both balloons are deflated after the stand deployment. This is one example of an ostial LAD lesion, yeah, but the scene in the quarter view, and then after pre-dilatation, the stand is placed there, and then a balloon from left main into the circ, and then the balloon is inflated first and then pulled back the undeployed stand, and then until a dent, and then deploy the stand. So this is how it looks like. After the final post-dilatation. The IVUS in this case showed a little bit of a protrusion of the sand strap into the circ, but not much. And it still allowed this balloon to go in and out here, freely without any resistance. For this particular patient, 2 years later, she came in with another episode of chest pain and had an angiographic study, and there is no in-stent restenosis. The ostium of the circ also looks good without any significant narrowing. So this is the stand drawback technique. A few words about this ostial LAD lesion. We should always consider whether we want to precisely position the stand at the ostium, or is it better to stand across the circ back into the left main. Several factors to be considered: the presence of stump, the bifurcation angle. The wider it is, the more favorable it is to try precise ostial positioning of the stent, and then whether there is presence of significant disease in distal circ or ostial circ, and the presence of calcification and the eyebrow sign on the ibis. Yeah. Okay. Lastly, there are a few things to consider to minimize the likelihood of an ostial PCI complication. One is a guide catheter dissection or occlusion. Generally, it's good to choose the less aggressive guide catheter unless really need a lot of support, careful manipulation, and consider preloading of the guide wire for rapid rewiring and catheter disengagement. And then to prevent the geographical or to minimize the geographical miss, we should have an optimal angiographic view and appreciate the relative position of proximal balloon marker to stent edge. For example, in the panels below, you can see that the balloon marker to the stent edge differ depending on the type of the stent, and on the Zycera, it is actually right at the center of the marker. Most of the other stents, there is a short distance between the center of the balloon marker from the edge of the stent. So we should take a good look at the stent before we advance the stent in for the ostial stenting. Then this partial or slow pre-inflation of stent, allowing a little bit of adjustment if necessary, is another technique. This is a little bit like the TAVI procedure when implanting the S3 valve, a slow pre-inflation and then a more rapid final inflation. Then the Sabo technique, the stent drawback or pullback technique, the aorta free floating wire technique are helpful. And if breathing causes excessive movement, some breath hold or shallow breathing might be helpful. And to prevent excessive proximal stent protrusion, like in our case example, adequate lesion preparation is important. And again, the techniques that we have gone through will be helpful. And for aorto-ostial lesion, be careful not to distort the stent, causing longitudinal stent compression. It's good to choose the coaxial guide catheter and less aggressive guide catheter, and also pay attention to the stent selection. Nowadays, most stents have a proximal reinforcement to minimize or to reduce the risk of a longitudinal stent compression. And then the guide catheter disengagement when withdrawing a trap side branch wire. That is the moment where this longitudinal stent compression is likely to happen because the guide catheter gets sucked in when we pull on the trap side branch wire. And then to prevent the second wire getting under ostial stent strap, for example, we have placed a stent in the left main up to the ostial left main, and we need to rewire the circumflex artery. Sometimes this second guide wire gets beneath the stent strap, and then that may create problems at the ostium or the left main stented segment. So adequate post-dilatation is important. Using double lumen catheter is very useful, or we re-engage the guide catheter over stent balloon before the balloon withdrawal. So we have gone through a few key learning points. Yeah, as a backdrop to the cases that Dr. Liu will show afterwards, and that we will together discuss, that there should be appropriate indication for ostial PCI, and then a careful selection of guide catheter, the angiographic view, and then we have also seen the usefulness of intracoronary imaging and physiologic assessment. Adequate lesion preparation cannot be overemphasized. And there are various techniques for precise stent placement. And after the stent deployment, a high-pressure post-dilatation is mandatory for the ostial lesion. Thank you very much.
Thank you very much, Prof. Lim. Excellent talk. You covered not just the ABC, but you covered more than the ABC for us. But I think very good. You gave us a lot of practical tips. I just like to check whether there are any questions. If there are no questions, then I will move on to my talk. Then we can catch up with some other cases that we can do as a many case discussion. So I'm just checking here. I think currently we don't have any question. We keep the question. I think I'll do my talk first and then we'll come back. Let me share this. Okay. Can you see my slides there? Yep. Can you see my slide there, Prof. Lim?
Yes, very clear and
Okay.
very nice.
I'll make a start with my talk, then hopefully we can catch up with some questions and also some cases. Okay, so I'm tasked to speak about Szabo technique for ostial lesion. I'll cut the chase. So I'll go straight to talk about what is Szabo technique, why the Szabo technique, which lesion. In some way, we do have to know there are some case, selection process. How do we do it? Step by step, and of course, troubleshooting. So you can see from the diagram there, and I think Prof. Lim has briefly explained, in the Szabo technique, we actually use two wires. The wire which is going to the target lesion, in this case, the picture shows the LAD, and then the wire that goes to the side branch, which is the circumflex. And we use the second wire as an anchoring so that the stent can actually precisely place at the ostium. So what's Szabo technique? This is actually described by a cardiologist by the name of Szabo, but there's very little known other than that. I tried extensively to search him, but as much we can get is just the publication is actually from the American Journal of Cardiology in the year 2005. That wasn't long ago. It was also known as a tail wire technique for coronary lesions. This is to ensure a very stable, precise stent coverage at the ostium without excessive protrusion of the stent into the aorta or a respective main vessel. The modified technique is also used for aorto-ostium, as what was said just now, the free-floating wire technique, or sometimes called the sepal wire technique. So when do we use this? Well, as we heard, ostial lesion can be a special challenge. The limitation from the different views, sometimes you can get foreshortening, you can overlay, sometimes have tortuous vessel overlying, parallax, where you don't actually see the true plane of the ostium. And of course, particularly the aorto-ostial plane and angle. And not just that, we also heard there's relative coronary motions, sometimes very difficult to catch the lesion with the stent missing, the ostial lesion. And of course, in some patients who are cooperative, we can get them to hold their breath in apnea, but that's not always possible. Whether it is a language barrier or a patient who has a hard of hearing, they can't follow instruction very well. And then, of course, as I mentioned, there is this risk of geographic miss when the stent is deployed and is slipped, and then we have to put another stent to cover the ostium. Or worse, sometimes the stent comes out too much sitting in the aorta. So in terms of the case, this lesion selection, you heard that in ostial lesion, we broadly classify them into the bifurcation ostial and the aorto-ostial. So for the bifurcation ostial, we can look at this technique whenever we deal with a pure osteal branch lesion. For instance, a 010 or 001, and of course, potentially you can do a 011 lesion. For the aortic osteal, of course, the left main and the RCA. For the bifurcation osteal lesion, the angle should be less than 70, but it can be modified if the angles are wider. If we have put a wire in, and the angle can be reduced, it may make it more favorable. I'll show a case later. But we do have to be careful in very extreme tortuous vessels and angulated lesion and the calcified lesions. These usually are difficult to cross and difficult, for stent placement. So step by step. First of all, the approach. It can be done with either radial or femoral. Intravascular imaging is an option. It can help us to see the lesion better, assess, especially in bifurcation, the plaque burden. In terms of guiding catheter, it's very important we have a good coaxial support. A 6 French is feasible, but in some lesion, maybe a 7 French is better support. The optimal view is very important. And assess the lesion, as I mentioned. Now, in terms of guide wire selections, we should use our workhorse wire most of the time. I preferred my BMW wire. In the literature, there is mention about avoiding a coated hydrophilic wire, just for that anchoring wire, in case as we advance the stent, and also as we pull that wire later, we might strip the coating. And as mentioned, very important in PCI that we have to prepare the lesion well before we stent. And for stent, the stent system that we use is the monorail systems. I don't think we use that many other types of stents. For instance, self-opposing stents these days. Then about the stent. Now the stent is prepared, by inflating a low pressure. How to do that is most of the stents come with a protective sleeve. And we don't remove the sleeve completely, but just to pull it back to expose the proximal strut. Now, when we talk about proximal, we are talking about, from the perspective of introducing the stent into the vessel. So the proximal is actually, from the perspective of the vessel, the blood flow is the tail end. So then the remainder of the stent is still actually compressed within the sleeve. And then we take the side branch wire and then pass it through the last strut of the stent. And then, we crimp the stent back down, the strut which is actually lifted, but not too tight that it will actually, obstruct, the wire movement. Then we mount the stent as usual, onto the primary guide wire of the target lesion. And keep these two wires as parallel as possible and advance it and enter, your 2E and into the guide. And we do so very carefully as we advance it, taking note that, it should be very smooth. If there's any resistance, it's good to do that under fluoroscopy and see where is that resistance from. Often it is around a bend. For instance, if we're doing it from femoral, as we come up the descending aorta, to the arch, sometimes they might have as a resistance. Less so if we do radial. Once we reach the guiding catheter and advance towards the lesion, the ostium, then we have to do it very carefully, while observing that the wires are still maintained in parallel, and hopefully the stent can advance into the ostium and stop by the anchored wire. And this is where we would check the position and confirm it with the angiography. And if you have stent boost or equivalent technology, it's useful to see that you have good anchoring at the carina. Then we deploy the stent at nominal pressure. And after that, we pull back the balloon slightly and go a little bit higher pressure by another maybe 2 or 4 atmosphere to make sure that there's a bit of flare. After that, we can do an angiography, and to see the result and to see that the stent has deployed, and also to observe the ostium, whether the adjacent side branch ostium has any compromise, like plaque shift or carinae shift. Once we're happy with that, then we can retrieve the balloon, but do that very carefully, because the tendency sometimes the guide, can get sucked in. And that's where the risk of compression defect to the stent edge. And of course, we can optimize the stent, after that, with a post-dilatation balloon. The anchoring wire can be removed before or can be removed after, the post-dilatation balloon. Depends on the situation, depends on the side branch, whether there's a risk of compromise, and of course, whether there's any additional steps or to treat the other side branch. So this is just a picture to show how we mount the stent. So this is the stent. You can see this is the advancing end. And this already shows that the wire already passed through, the flat, the sort of the tail end of the stent. And then the stent is also mounted onto the primary wire. Now, what is important here is to crimp the stent down. As we crimp it down, we have to make sure that it is smooth. Use a finger to run through it to make sure it's smooth. And that's actually important just in case. If the stent does not cross the lesion, we have to retrieve it back to the guide. We want to make sure that end of the stent is not lifted, the struts. Otherwise, you can get into trouble, not able to retrieve into the guide. Troubleshooting. What can go wrong? Resistance during advancement of the stent within the guide. That's usually because the wire, even though we try as best to keep it parallel, they tend to twist, especially going around a bend. As I mentioned, the aorta, the arch. Resistance to cross the lesion. This is where the stent actually has come out the guide, but just wouldn't reach the lesion. That can be many reasons, and I'll walk through some of these later. The resistance to advance the stent fully, unable to retrieve into the guiding catheter, stent dislodgement can happen, and stent edge compression defect, as I was mentioned. Very rare. The stent balloon failed to inflate, and we'll talk about that in a bit more detail. And post-stenting, you might have plaque shift, carinae shift. So first, if there's a resistance during the advancement of the stent, this is within the guide. This is often because the guide wires are twisted within the catheter. Well, maybe because of the lumen a bit small. Most of the cases, of course, we do with 6 fans, shouldn't have an issue. But occasionally, you do find there is more resistance. And as I mentioned, coming from the femoral because of the aortic arch, that might give you trouble. Anticipate this during the test run when we do pre-dilatation. After we do pre-dilatation, the wing balloon, you can actually try to make a test run and see how it feels. If you feel there's any resistance, then anticipate you may have problem with the stent. How to prevent that is to keep the guide wire as parallel as possible during the procedure. But otherwise, there's no choice to retrieve the wire and then reintroduce the wire. The second thing is the resistance to cross the lesion. This is when the stent has exited the guide, but it gets to the lesion, but near the target, but not able to advance. This is where the guide wire is twisted outside the guiding catheter. And I have an example to show you later. And anticipate this again sometimes after we do the pre-dilatation. And the same troubleshooting, the same solution is to retrieve the wire and then rewire. Now this one is a bit more. This is resistance to advancing the stent fully. Can be many factors related to the lesion, the vessel, and the device. First and foremost, suboptimal guide support, not coaxial, not enough support. So as we always say in PCI, we teach everyone from basic. A good guide is very important for any PCI. So optimal guide choice. Very rarely we might need to have a guide extension. Bifurcation, angle, a spline carina, and all this can also give you resistance to tracking a stent. And sometimes the extra body wire can be helpful to reduce that angle. Inadequate lesion preparation. That probably, is probably the one of the most important point. So very important to optimal lesion preparation. As mentioned just now, use sometimes scoring balloon for lesions that are hard calcified. And as heard, we may also do some kind of atherectomy. Sometimes the lesions are very long. We focus so much on preparing the ostial well, but we forget further down in the proximal segment or mid segment of the lesion, there is also, a tight stenosis, and the front end can't get through. So sometimes we have to remember to prepare the entire lesions well. As mentioned, tortuous vessel, very angulated lesion, we might need extra wire. Long lesion, I've already mentioned, and in some cases, unfortunately, when we have really difficulty with the long stent, we might have to give up on the long stent and then, use two stents and deploy a stent distal first, come back, to put in the ostial stent. Then we might still be successful with a Szabo technique. The stent edge can flare, at the advancing end. That has happened. If we look carefully as we look at some of the stents, even though we have the protective sheath on top, as we inflate, even though we say we go low pressure, 1 to 2 atmosphere to open up, the tail end of the struts. But sometimes we have to go higher pressure, sometimes up to 4 atmosphere. And when we do that, look carefully at the advancing end of the stent. The stent sometimes can open up. So I usually keep my finger there and pinch the sheath, so that, that doesn't happen. And then when I take it out, I inspect it carefully. Okay, another problem. Unable to advance, no choice, we have to retrieve. And unable to retrieve. And of course, that usually, if people are not careful and pull too hard, you strip the balloon off the stent and the stent is dislodged, hanging outside the guide, but still on the wire. So very important as we do this, we carefully withdraw and don't strip it off the balloon. How to prevent this? Well, try to make sure the guiding catheter is aligned well to the stent as we pull back, not at an angle. As I mentioned, of course, if this happens in the middle, already in the middle of the procedure, you won't be able to change your guide. But if you foresee some of this difficulty, perhaps a larger guide with a larger lumen is better. And also mention, crimp the stent edge down properly after we hook the anchoring wire. If we're still unsuccessful despite multiple attempts, one thing to remember is not to inflate the balloon. Okay, some people thought inflating the balloon might help. But once we inflate the balloon, we loosen it up, we're going to have a higher risk of dislodgement. The option is to withdraw, unblock. So, to take out the whole thing. Getting the guide, the stent and wire out, back into, let's say from a radial approach into the brachial artery. Idea is to avoid the stent embolization into the brain, the vital organ. And from the femoral approach, retrieve it down as much as possible back into the iliac vessel, iliac femoral. But of course, there's a situation, you read here, I say, there is an option sometime we can consider deploying the stent if we are unable to cross that ostium. So this is where we convert, we had to resort to stenting. In this case, let's say, instead of an ostial LAD, stent the left main and LAD. And then, of course, we had to put another stent to cover the second stent to cover the distal end of the lesion. We had to do that. Okay, stent edge compression defect. We have to be very careful as we withdraw the balloon. because the guiding catheter can get sucked in and crush and compress the stent edge. And to prevent that, it's important to dilate the stent after we post-dilate, pull back the balloon, and repeat the dilatation to make sure the struts are well opposed to the vessel wall to minimize that risk. And as we say, maintain the traction on the guide, and it's very important. If that happens, of course, we have no choice. We had to go back with the balloons, sometimes smaller balloons, and upsize gradually to correct the deformity. Now, stent balloon fail to inflate, and often, we keep inflating, but the balloon doesn't go up. And of course, if you're careful, you might see there is actually contrast leakage. So this is where the balloon somehow has ruptured. Suspect this, especially when the balloon, as the time when we put the wire onto the strut, we might actually have poked the balloon and damaged the balloon. So prevention is key. Always open the last strut well, turn on the light and, make sure, as we pass the wire, we don't damage the balloon, and keep the wire, as parallel, and not, poking the balloon. And of course, as you crimp the strut down, also be careful, because the struts are hard and, they can damage the balloon if we are too aggressive to crimp it down. If that happens, of course, we have to, if the stent is partially deployed before it sort of leak, then, we might still be able to retrieve the balloon carefully, but not to dislodge the stent, and hopefully it can go back in and post-dilate the stent. But if it did not inflate at all, then I think, we have to consider retrieving the system back into the guide. Okay, so plug shift, choroidal shift, that can happen, even though, we assess the lesion, we think, the side branch is disease-free, we don't intend to do anything more. But of course, if you have, a plaque burden which is around the carina, if you've done intravascular imaging, you know that, the ostial lesion, has plaque on the carinal side, then of course that risk is higher. If the side branch is small and the bifurcation angle is narrow. Anticipate that, especially we do pre-dilatation. We do the balloon, pre-dilatation in the lesion preparation, and you start to see there's some plug shift, some snow plow, anticipate this issue. This is where, if it happens, we had to assess whether there's functional significance. Of course, if there's a TIMI flow disturbance, there's a large territory, and the FFR, if you assess, is impaired, then you have to salvage the situation. Case-by-case basis, of course, then it's about converting from, a single stent, ostial bifurcation to consider now a two-stent strategy. Now I'm going to show some cases. Here's one example of an ostial left main. You can see here, it's a very tight ostial 90% lesion. This patient presents as an acute case. This is an AP cranial view. The right side here is a spider view. So in this case, anticipating is a very tight lesion. The wire, the moment it goes in, as you can see here, you really start to have impedance of flow. So very important in these cases, before we cross the wire, we mount a balloon on the wire and keep it ready. So the moment you get the wire down, do the balloon dilatation. Minimize the ischemic no flow time, and hopefully patient don't destabilize. And in this case, after we've done the pre-dilatation, after we've done the pre-dilatation, we decided, we could use a Szabo technique, or what we call the free floating wire technique. And we put the second wire into the aorta. So in this case, the wire, exited from the guiding catheter, make a turn, around the cusp, and then we advance it up to the arch and let it, anchored in the descending aorta. The deeper, the better for support. You can see here better in the cine. Just now was a fluoroscopy. It was on the burns very clear. So you can see here two wires, one in the LAD, and the other wire is actually up the aorta. And this portion is actually descending. So here we advance. We already done the pre-dilatation of the lesion, and we're now advancing the stent. You can see the guide, it does kick back a bit, but because it's back up into the cast, so you're still able to have support to advance the stent. So once the stent is pushed up against the ostium, it is anchored by the wire at the kind of upper lip. You can see here it is deploying the stent. And after that, we gently pull back the balloon and repeat the dilatation to make sure the osteo is properly flared. You can still see the anchoring wire in situ there. Then we're happy because it's the aorto ostium. We remove that side branch wire, and that side branch, sorry, the aorta wire. And then we do post dilatation with a non-compliant 5 millimeter balloon. And again, be very careful, every time we handle the balloon, traction, do it slowly, don't rush, snail pace, as I say, then we don't damage the stent edge. So that's the final result for this case. So there's an example of an aorto ostium. Now there's another case here. This is a patient with this is an osteo-LAD. Now this is a patient with a occluded osteo-LAD. This is RCA, of course. You can see this collateral filling the LAD. You can see the stain here, the contrast. Okay. So anyway, we managed to get a wire down the circumflex, which is a very large circumflex. You can see here the guide. This is actually a very short left main, and the wire here is actually, going into the LAD. That is either a small diagonal one or a ramus branch. And then we do a pre-dilatation. So we got 2 wires down, and we get pre-dilatation. We got the flow, and we can reassess this lesion. So this case, illustrate a few points. Very important in this technique, Zabo, to look at the angles. I highlighted here a few things. I drew here also the guiding catheter, the axis, the left main axis, the LAD, osteo LAD axis, not the mid segment, and also the circumflex axis. You can see here, ideally the guiding catheter and the left main and the LAD should be all aligned. That would be the ideal candidate for osteo stent and a Zabo. In this case, the wide angle, also in a big osteo, the circ, which is disease-free, also facilitate good osteo placement. So if you look at the wire here, if it stay parallel as we approach with the stent, that's always a good sign. With the experience that we had so far, when we have that, usually we have a successful pass. If we don't see that, be careful. So here's an example. The wire is straight up, the guide is straight, left main is short, LAD is straight. Circumflex, even though you take off at almost a 90-degree, it's okay. You can see as we advance the stent, the wire is also not crisscross. And you can push against the ostium, the guide kicked out a little bit, that's okay. Then you can deploy the stent. And after that, after stenting, reassess the circ if you're happy with the result. And in this case, I was happy. I sometimes prefer to rewire it before I do, the post-dilatation. So in this case, I did that. So after I get, the stent deployed, I post-dilate with the stent balloon. I'm happy. The circ is no compromise. I take the wire back, and then I get the wire down. In this case, I managed to make a little knuckle. And this is always good because then I know I'm not going through the stent strut. So then I proceed with the post-dilatation. Then very careful, as I mentioned, each time we'll take the balloon back, make sure we don't get, the guide suck in. And this is the final shot. We managed to get the stent re-engaged. And this is the final result. So I've shown you 2 good cases of aorto ostium, and one is a non-aorto ostium. Now this case is another osteo LAD. You can see here this is in the AP caudal or AP caudal view. Again, the left main, the circumflex is relatively normal. There's a LAD osteal disease. And here in the spider view, this is slightly different from the previous one because the angle of the LAD in its natural form without any wire, is more like a 90-degree now, from the left main. So, that you have to anticipate you might have some difficulty. Okay, so here's an angle of the left main to the LAD and the circ. Of course, this is a bifurcation between the between the LAD and circ is very wide. Now, it's very important in this case that we reassess after we wire. So once you put the wire in, and then you reassess the angle. So you can see in this case, once you wire the LAD, the angle is, somewhat a bit friendlier. It's not so, not so wide. Yeah. I didn't have a picture here of the pre-dilatation. What you see here is actually a lesion which is already, prepared with the pre-dilatation balloon. Huh? Okay. Now, so here is pre-dilatation. In this case, I use a non-compliant balloon to do pre-dilatation, and this is after the pre-dilatation. And now, we think we have adequately prepared the lesion. We advance the stent. In this case, we were advancing the stent in this AP cranial view. You can see the stent advance and then it's stopped by the anchored wire. So if the wire crisscross, that's always a signal you might have difficulty. So, if you foresee any, resistance, be careful. That's where we have to be careful not to lose the stent. Like in this case, as we push the stent up, you can see how, it kind of bow, the wire bow away from each other in the left main. You can see the guide kick back a bit, but as long as it reaches the target, it can still deploy. But if it doesn't, then of course, you have to make a decision whether to actually, retrieve it. In this case, it was successfully deployed and then it was post-dilated. I'll show you now one case which is not successful. This is the last one I have. So here is a case of, again, Ostial LAD, and again, much more angulated compared to the last one from the left main to the LAD. And it's a trifurcation. We have a ramus as well as a circumflex lesion, circumflex vessels. So again, the wires are passed. In this case, I choose to protect the circ first. Okay. Then the pre-dilatation was performed to the LAD. Now it's not as clear, but if you look carefully, you can see the stent is actually within the guide. So if I can stop it, let me see. No, I can scroll this. Can you see that there? So there are two dots within the guide. There's one, there's one. So the furthest you can is just before the guide. It did not come out of the guide. You can see how these two wires become almost one. So this is where the wire has become somehow twist and become tightly wrapped. And, we rewire it, but again, mount the stent again one more time, it still happens. So in this case, we decided to abandon. In this case, what I did is I pulled back the circumflex wire and just go ahead with deploying the LAD stent. Okay. And of course, after the stenting, you can see there's some plaque shift. You can see the carino has ostial plaque shift, even the circ also eccentric in the AP caudal view. There's more in the spider view, not so much. The patient has no symptoms, pain-free. I decided, to manage this conservatively. So that's it. So Szabo technique is relatively simple technique to master, but there are, some pitfalls and some possible complications. I think the lesion selections are important. The preparation, the steps are very important. And I think, as we say, prevention is key. Knowing when the trouble could come, but not, still, heading for it. Know how to bail out is important. With that, thank you very much.
Excellent talk, Hong Quang. learned a lot from your talk and the cases that you show. Yeah.
Love to hear from you whether there's any tips on your end as well.
Oh, you shared so many great tips. This Kim Hui has another tips that he mentioned.
Yes.
Yeah, when he cannot advance the stent to the target ostium, whether still in aorta or within the left main, then rather just pull out the anchoring wire and try to place the stent in the usual way by checking position in multiple views.
Yeah.
Yeah, apparently Kim Hui said that he has lost a few stents previously. Effort to retrieve the stent. I think many of us had this type of experience.
Yeah. I had two times. I happened to be twice. Lose the stent, can't get back the guide. I think whenever you see the wire bowing away, and it crisscross, I think the strut is lifted up again, even though you crimp it down. So that is where, I think when we retrieve it back to the guide, we often have problem. So I think if I see that sign nowadays, I sometimes just prevent by not pushing. Just, just come back.
Yeah.
Anyway, do we have any questions from the room? Let's check. Okay, let me see. Can you see the question there, Prof. Lim? I'm trying to change the format of the room so I can see the question.
There are actually a lot of questions for the Sabo technique. Hong Bang, you want to have a look, give me two comments, and then you look at the unanswered part, unanswered. Yeah.
Okay. How do I get to the question? Oh, okay, I found it. Q&A. Okay. It's from Kim Hui. So, open question. Just a comment. Often, if I cannot advance the stent to the target lesion, still in the AO within, I just pull out again. Okay, so that's what you mentioned just now. Sabo is also good to reduce the need for multiple contrast injection to check position. It's snag in Ostial. Yeah, I agree. Yeah. Okay. Great.
Did you see answered the central tab?
Okay. So there are, I can see open 2, answered 5. Okay, let me see. Would finger crimping cause stent deformation and loosen, I think, or drug coating as a result of restenosis risk? Okay. Good question. I think crimping the stent, just that the edge is probably minimal damage to the polymer, or it is a drug coating. And don't forget, I think that is usually the part which is not really inside the ostium. That part is actually sort of the bit which is actually just sitting at the carina, a little bit out, I think. So far, we have some angiographic follow-up with our cases. I have not seen, that many restenosis. I think if there's restenosis, it's often because of inadequate lesion preparation. I mean, Prof. Sutek, I'd like to hear from you. Like say, even with stent, Zabo or no Zabo, when we do an ostial lesion, if we find that, there's a remnant, a stent under expansion, those are usually a signal that, you're going to have a long-term risk of restenosis. But you've got to perfect the deployment, and I think most of the time they do okay.
Yeah, agreed. Agreed. I think that's why I think the need for adequate lesion preparation cannot be overemphasized for the ostial lesion. Yeah,
I totally agree.
Yeah,
especially aorto-ostium.
Yeah.
Yeah. The aorto-ostium, I find that sometimes, what is it? The stent eccentricity and so on, and smooth muscles is what people say, isn't it? Now, there's the question here: would using multiplanar angiography? I think this one is for you, Prof. Lim. Using multiplanar angiography, checking for stent placement as good as Zabo technique.
I think each has its own roles, right? Yeah, like what Kim Hui said, right? Yeah, using the Zabo technique, and as your cases are elegantly illustrated, yeah. Once the stent is now at the ostium, then you may not need to take so many other view. But the multiplanar actually doesn't use a lot of contrast. Doesn't use a lot of contrast. So I liked it, but then it's not available in a lot of the machine. I think the two-dimensional rotational angiogram, as far as I know, probably only in Philips machine. Some of the other machine are actually the either quarter or cranial rather than two-dimensional. But it serves more or less the same purpose of having a multiple angles looking at things.
Yeah.
Hong Bang, there is a question. Hong Bang, there is in a bifurcation ostial lesion, usually we would wire both the vessel and do pre-dilatation first. So if we plan to do Sabo technique, we require a third wire for anchoring purposes. There is the question number 3 under open tap.
Let me get there.
Do you see that?
I see it, yeah. So the bifurcation ostial lesion, usually we would wire both the vessels and do pre-dilatation first. If we plan to do Zabo technique, we would require a third wire for anchoring wire purpose. No, we don't. I think when we talk about, let's say, in this case, 011, is that right? Yeah? Let's say we talk about 011, so you feel that both the branches needs to be treated. Yeah? Yes, if you feel that both lesions have to be treated and you choose to pre-dilate them, then of course you can stent each one using the Zabo technique that has been described. So what people do is, for instance, they do the LAD, they would use a circumflex wire as the anchoring wire and deploy the first stent. And then after that, when they completed it, they rewire, and then they take another stent, and now they pass it with the LAD wire, as the anchoring, and mount that stent onto the circumflex wire as a primary wire, and then they pass it down. So I've seen that being done and reported before. But of course, after the first stent, people post-dilate the first stent, deal with one first, do that well first, then come back and do the other one. That I think is provided if you are confident that there's no left main disease. You can do an ostial placement of both the branches there. Anything to add, Prof. Lim? What do you think?
No, I agree fully with what you said. Yeah.
Yeah, but I think that's very rare, to have pure ostial lesion branches and no lesion in the left main at all. Often the time, if you find, this sort of situation, especially if the left main looks smallish, like 3 millimeter, I think I always say, get an IVUS and have a look, because you might have tubular disease in the left main, which might be a 4.5 vessel. Then you may not want to do, stenting of the ostial only. You might have to consider left main LAD stenting, and circumflex stenting. Any other question there? Let's see. Are there dedicated devices for ostial stenting?
One, the Capella one, I think no longer available. I think, yeah, it's very difficult. Yeah.
All right. That one, I think, is Boston. It was a Boston Scientific Technology, isn't it?
Yeah. One more question under the open view. Do you see that? For anonymous attendee.
Medina 001 bifurcation, isolated acute angle side branch. If stenting needed, how will the optimal stent position not to miss the ostium or the side branch lesion, but not protruding too much into the main branch? Will you crush the stent edge that protrude into the main vessel? I'll read that one more time. Medina 001. Bifurcation, isolated acute angle side branch. Okay, stenting needed. How will the optimal stent position not to miss the ostium in the side branch, but to protrude not too much into a main vessel will be crush the stent edge that protrude into the main vessel? Okay, so I think this is a case of where you have 001 referring to a pure side branch disease only. Is that right? Where the main branch proximal and main branch distal has no lesion.
A little bit like the isolated ostial diagonal
Yes.
with an acute
Right.
angle, and if we intervene on it, part of the stent may stick out.
Yeah. I generally avoid stents in that kind of lesion. The main vessel has no disease, and it's only side branch disease. I always very, very conservative, and unless there's very strong evidence of ischemia, either clinically the patient manifests, or there is exercise tests, or of course on table you have a FFR. But of course, if you really have to do it, I would say that depends very much on the angle. And as you say, you don't want to compromise your main branch. Just for a side branch, the Chinese said 因小失大. Just because you want to do the small one, you compromise the big one. If I'm the patient, I wouldn't be happy. So sometimes, a longer inflation, you may make sure the flow is returned. Last resort, I stent. That's my take. But if I had to stent, I would probably, consider T-stenting if the angle is suitable, or I would consider some technique, like what the Prof. Sutek has mentioned. Put a balloon there, a drawback, just make sure that it doesn't protrude too much. I don't know. What do you think, Prof. Lim? You're more experienced with this.
No, I think that, like we mentioned earlier, I think we need to carefully consider whether we really want to do it. I agree with you. I think that if it is not supplying a very big area, a very large territory, perhaps we can treat with medical therapy. There's one option. From the study that we quoted in the slide earlier, the conservatively treated patient may not, in that particular study, actually fared better than the invasively treated patient.
Conservative.
The other option sometimes is to consider just a thin balloon with a drug coated balloon the delivery, so that to minimize the damage to the main branch. But there is still a possibility of a plug shift. It is a very difficult situation for this 001 lesion with an acute angle.
Yeah. Okay. But if you must stent, you must stent. And, no choice. And of course, then you consider all these options where you have to maybe even stent it. Sometimes you're right. You might even have to stent it into the main branch.
Main branch,
reopen the, the distal segment of the main branch.
Yes. So one attendee actually helped us answer also the any road DCB. Yeah, I think that is one scenario to consider.
Yep.
Cutting balloon.
And as a last resort.
Yeah.
Okay, another question there. This is in a bifurcation ostial lesion, usually we would wire both the vessels and do pre-dilatation first. I think we answered that one, eh?
Yes, answered already.
Oh, there's another one down here. No, that's it. Do we still have time? If there are no questions, shall we show some cases? Do we still have time?
You have prepared your cases, I think.
Yeah, but what time are we supposed to wrap up? Is it 7 or 7:30? Somebody has to remind me. 7. So we got 2 more minutes. Prof, would you want to show a case of yours, or?
I think you show yours. You prepared many. I think.
Yeah.
You show yours. Yeah.
Yeah. Okay. So it's 1 more minute. I don't think we can. I think the organizers are there. I don't think we have any injury time. Got injury time, with no injury time, then we have to wrap up. No penalty time. Can. They said can. Okay, so let's just show one. Let's see. Maybe I pull out. Okay. Give me a minute. All right. I'm going to share. Let's see. Share screen. All right. Okay. Can you see that? Yeah.
Yeah.
Right. So here's a case of a 66-year-old man with a lot of risk factor. Hypertension, high cholesterol, diabetes, and he has a previous, triple vessel disease and had PCI done before. And he came back with a non-STEMI. And of course, the first suspect is restenosis. And voila. And here's one. And we see here, hold on, let me just, okay. So we see here, this is a RCA with, sorry, let me go back again. Sorry about that. Right, so this is the RCA with a proximal stent before, and there is a proximal stent edge restenosis, which of course involve now the ostium. We also see in the distal, there is the crux disease extending into the PLV. And I think it's very tight. You can see the TIMI, 1-2 flow in the RCA. As a close-up, there was a diagnostic. This is a guide. And you can see there the lesion there. Okay, so what do we do? So in this case, we had the BMW wire, passed into the lesion, and we're able to advance that wire into the PLV, and then we started doing some pre-dilatation. I think the distal, we used the 2.5 balloon, the proximal, we used a 3.25 NC balloon, expecting this, in-stent restenosis lesion is a, fairly hard, chronic fibrotic, intimal hyperplasia. And as expected, we can see there was a waste on that balloon during the pre-dilatation. This is an NC balloon, by the way. You can see, yep. So there's always the eureka moment, you see the balloon, the waste goes away. It's always a good sign. So we managed to do that. And this is the result after pre-dilatation. Then we follow by stenting. And here we use a create stent. In some way, it is a good stent with the markers. They are good for placement to see where, exactly your stent is. And in this case, of course, you can see we placed it slightly outside the ostium. And then dilated. I think I didn't show all the steps, but I think the technique you mentioned was very important. Once we have stented, I usually keep the balloon, in the stent, and then advance the guide. After I flare the ostium of the stent, of course, then I advance the guide into the stent with the balloon in situ. Then slowly retrieve the balloon into the guide. And that usually will prevent the risk of the stent getting crushed by the edge of the guide. So
that is a very important point, Hong Bang.
Yeah.
Technique that also used in renal artery stenting, and for left main ostial RCA. I think this is very important technique, and also a little bit the similar principle to having a balloon while advancing, leading the advancing edge of the guide extension catheter.
Okay.
Yeah, reduce the trauma, you reduce the space, and then you also make it less likely to injure the surrounding structure. Yeah, but very important point. Very important point. Yeah,
that's good. I don't use that much of guide extension. Maybe less than once a month, but that's a good point.
Mm-hmm.
Thanks for that tip. Do you want to see another case?
Yeah, the Hong Bang, you have one more case from you according to
Only one more. Is it still on screen? Am I still on screen, or I have to share again?
You share again. Yeah.
Okay, hold on a minute. I need to go back to that. How do I go to that? Share again. Okay. Sorry. Can you see it now?
Yeah, yeah.
Okay. So this is a 45-year-old gentleman, security guard with a no known medical illness. That's not STEMI. And he got a non-STEMI in November 2016. So that was 5 years ago. Let me play this. Okay, so here's a patient with a Ostial LAD lesion, and he has a circumflex which is non-dominant, and there's probably a big, that's probably a big ramus as well. Okay, so there's a guide wire gone to the ramus, for anchoring as much as protection, and then now a second wire finding its way through the LAD. So we managed to go down. This is a pilot 50 wire going down the LAD, and there's still no flow despite wire cross. And then we use a balloon. I skip a couple of steps here. Some of this lesion, acute one. What I do is, if it's a simple cross, I always suspect it's the thrombosis rather than a CTO. I do a daughtering just with the balloon, and just to see whether I can get flow. I think in this case I couldn't, and therefore I do a balloon dilatation. So it was a 2.5 balloon. And this is after balloon dilatation, a review flow, and a long lesion in the LAD. Okay, and in this case, we decided, we need to stent it because I think there's a lot of recoil. So there's a long stent here. This is a 3x48. You can see there's a diagonal there, long, and they're probably diffuse disease as well. But in this case, I decided I'm going to just focus on the LAD for now. So anyway, there's a first stent in, and then after that, we had a look from the ostial, from the spider view, and we estimate the second stent. And I think in this case, we use a 3.512, and I'm not sure whether, I don't think this is Zabo. This is just parking across the ostial LAD and deployed. And as a result, okay, two overlapping stent of the LAD from the ostium down to the middle segment. Then there's post-dilatation. Post-dilatation in the distal, post-dilatation in the mid-proximal, and up to the ostium. So that's that. Any comment on that? Feel free to criticize. Should we have done more to the circumflex? Should we have protected the diagonal?
Okay, yeah. That's very good, very elegantly done,
Yeah.
If case many superb cases of great educational values today, and we certainly learn a lot from your cases and from your sharing of the Sabo technique, which is a very important technique, and you can appreciate that there's a lot of interest in this technique.
Yeah.
Yeah.
Great. Shall we wrap it up?
Yeah.
Okay. Are there any questions still? Let's check the Q&A. Let's not miss out if there's anybody.
And Colin just remind us that it's time to buka puasa.
Yeah, exactly. Right. Okay, there's a last question here. Would you rather use a semi or an NC balloon to flare up the ostium? Prof. Lim.
Yeah, I said that I generally use the NC balloon actually. Yeah, because I think the lesion tend to be more fibrotic and calcified. So I generally use non-compliant balloon. Yeah.
Same here.
At the time of the deployment, we generally pull back the balloon a little bit.
Balloon.
So there is that one is a semi-compliant balloon.
Yeah. Do one round of flaring first.
That's right. Yeah.
I totally agree with you because I'm for the, I always say we don't do as much IVUS. We love to do IVUS for every case, but because of cost and whatnot. What I teach my fellow is this, and since this is supposed to be a basic course, and this is my message to people, don't save on post-dilatation. When we do IVUS, we are humbled by what we see in IVUS. What angiographically looks okay often is not. So I always tell people, as a rule, always routinely post-dilate with non-compliant balloon. Unless you have an issue, like say patient, they have slow flow, you don't like to balloon too many times. Otherwise, I always teach my fellow, don't save on non-compliant balloon. Always post-dilate well. Anyway, I think that's all. Prof. Lim, would you like to have some last message for this session on osteal lesions?
No, I think we certainly learned a lot. I learned so much from you and from the interaction with our colleagues. And greatly enjoyed this session of Alvimedica Academy webinar session. I think it is actually, when we revisit some of these so-called basic principles, actually we learn. We learn a lot. And while we reflect back on the past experience, some of the mistakes made, and what we can together improve. So I really enjoy this session. Thanks, Hong Bang. Thanks, Alvimedica and Kanika for hosting this webinar, allowing us to interact together online, virtually. And thanks to all the participants and the attendees for the active participation and making this a very interactive and educational session. And of course, to our Muslim colleagues, Selamat Hari Raya Puasa.
Yeah.
I've
enjoyed this. I've learned a lot. And as you say, it is very important to share all these cases. Thank you very much again, everybody. And thanks for inviting. We will hope to have more of you, Prof. Sutek. I always enjoy your talk. I always enjoy, your case sharing. So hope to have more of you.
Kampung boy from Alasta. Okay. Bye-bye.
Take care, everybody. Okay, bye-bye.
Bye.